Our next speaker is Dr. Sherry Suplido, who is specialist from the Division of Maternal and Fetal Medicine of the Philippine General Hospital. Currently, she's a clinical associate professor of the UPPGH Department of Obstetrics and Gynecology, head of the Maternal and Fetal Medicine Unit of the Center for Women's Health at the Manila Med Hospital. She is also a fellow of the International Federation of Obstetrics and Gynecology. She's a recipient of the 2015 SS Ratnam Asia Oceania Federation of OBGYN Young Gynecologist Award. Here to give us practical tips on setting up a patient safety environment, we are honored to welcome Dr. Sherry Ann Suplido.
Good afternoon. I'm here to lecture on practical tips on setting up a patient-safe environment. Few days, we know that the trend cases is still in full stop. So today is May 1, and in 2 weeks, there's a possibility that the ECQ will be lifted. Let's see. So we notice that the different guidelines shift as the COVID-19 outbreak evolves, and that we have to be anticipatory that all healthcare facilities, whether it's in the OPD or in the hospital, should be aware of changes on how to make the environment patient safe. So what are our goals for setting up a safe environment? We have to minimize viral transmission. We can only achieve this through compliance to infection control guidelines. We should be able to protect our healthcare workers and, of course, protect and provide quality care to our patients and maximize resources without compromising safety. So the first part of my lecture will be on creating a patient-safe environment in the clinic, and later on, the second part will be creating a safe environment in the hospital. So the CDC recommends that as public health actions to preserve staff, PPE, and patient care supplies, and ensuring safety for patients and healthcare personnel, facilities should delay elective ambulatory visits through telemedicine. So Dr. Aguilar already explored alternatives on how to reduce the face-to-face visits in order to prevent transmission of respiratory viral pathogens. So we shouldn't go to the clinic without notifying our doctor first. And we cannot overemphasize that prevention of spread should be the #1 priority, and this can be achieved through social distancing of at least 6 feet. So our patient should call us first before going to the clinic, and no accompanying person is allowed in the outpatient clinic unless they are an integral part of patient care. So because any elective or non-urgent visits are postponed, Dr. Aguilar already showed you the alternate schedule for prenatal visits. So how do we prepare our facility, particularly our clinics? So we should monitor our healthcare personnel and ensure maintenance of essential healthcare facility and staff and operations. So we advise our nurses or in the clinic or our secretaries to check for any signs of illnesses before reporting to work, and we should screen them before entering the facility for signs and symptoms of COVID. Okay.
Yes.
Okay, so the CDC came up with guidelines for how to get our clinic ready for coronavirus. So before our patient enters the clinic, we should, by telemedicine, know which of our patients are at higher risk for adverse outcomes for COVID-19. So these are our diabetic patients, or relatively our pregnant patients with comorbidities, our hypertensive patients, or our elderly patients. We should also assess and restock supplies now and on a regular schedule. So we should ask our patients by telehealth regarding signs and symptoms, and consider rescheduling our patients for non-urgent appointments. So as doctors, we should also make sure that we are healthy before going to the clinic. So let's take our temperature first before holding clinic. Don't hold clinic if you are sick. Avoid touching your face. Don't share your clinic materials like your stethoscopes, and don't schedule too many patients in a day. So before I proceed with infection prevention and transmission-based precautions, what do we know or remember about COVID-19 and its mode of transmission? So it can be contracted via contact, droplet, or aerosol transmission, or through blood secretions and fecal material. So COVID-19 can be contracted over short distances via droplets from the respiratory tract of one infected individual into the mucosal surface or conjunctivae of another. Although the maximum distance has not been definitely determined, if you are within 1 to 2 feet or 1 to 2 meters or 3 to 6 feet of an infected individual, there's a chance that you can contract the disease. We can also contract COVID-19 via direct or indirect contact from the immediate environment. So we know that coronavirus can persist in plastic, paper, or glass, or wood, and that all equipment and surfaces should be frequently cleaned, especially when transferring between patients or potential patients. So although the droplet, coronavirus can be transmitted via droplet, and these are heavy, and they usually fall to the ground, and rarely do they remain suspended in air, but they can be transmitted via aerosols farther than 6 feet or 2 meters when they are propelled by a mechanical force, like in aerosol generating procedures. So they can be transmitted via aerosol transmission, and these are particles suspended in gas of less than 5 microns from the respiratory tract of an infected individual directly into the mucosal surface or conjunctivae of another person. So before in starting our clinic, we should make sure about ventilation and special air handling. So I've mentioned that since COVID-19 is mainly via droplet transmission, and most of that volume travel short distances and they fall to the ground, and rarely do they remain suspended in air, special air handling and ventilation are not strictly required to prevent droplet transmission. They're more required for airborne transmission. So the WHO, in their Infection Prevention Control of Epidemic and Pandemic-Prone Acute Respiratory Infections, claim that there is little evidence that ventilation directly reduces the risk of disease transmission, but many studies suggest that insufficient ventilation increases disease transmission, especially for airborne infections. So I will introduce you to a new term called air change per hour, which I just recently learned while doing this webinar. So air change per hour is the measure of air volume added to or removed from a space, and that's usually your room, like your clinic, divided by the volume of the space per hour. So 1 ACH or air change per hour is equivalent to the cubic feet or meter of the room. So that would be the length, the width, multiplied by the width and the height of your room. An average room has approximately 1,600 cubic feet of airspace. So the higher your ACH, it will correspond to better ventilation. So WHO says that lack of ventilation or low ventilation rates or low ACH are associated with increased infection rates or outbreaks of airborne diseases. However, no data exists on the impact of ventilation rate or ACH on the transmission of droplet transmitted diseases. So this agrees with the physics of droplet transmission because they're heavy and they fall to the ground. So in general, ventilation should not affect large droplet transmission. But there are studies saying that high ventilation rates could decrease the risk of infection. For example, in a small room with an ACH of 2 and a ventilation rate of 13 liters per second, it was associated with higher tuberculin tests among the staff. So higher ventilation rate is able to provide a higher dilution capability, that's a higher ACH, and consequently reduce the risk for airborne infections. But even so, because COVID-19 is, the data about COVID-19 is evolving, we still want that our triage and waiting areas are adequately ventilated. So for outpatient departments, the minimum ACH is 9 or a ventilation rate of 60 liters per second for a patient. So in our clinic, when the ACH is used to measure ventilation performance, the volume of the enclosed room is clearly an important factor. For a given ACH, like a ward with a larger volume, it can provide a larger airflow rate and better ventilation, so reduce risk for infections. If you open the windows and the doors, it will provide a median ventilation of 28 ACH, so that's better. And we encourage the use of exhausts for confined rooms to provide unidirectional flow. So, but for airborne, we should have airborne precaution rooms for diseases which can be transmitted airborne. So an airborne precaution room is a room with at least 12 ACH, equivalent to a ventilation rate of more than 80 liters per second, and a unidirectional flow. So this was advised after the SARS epidemic before, but currently there is no clear definition or a precise list of high-risk healthcare procedures during which pathogens like SARS or COVID can be spread through droplet nuclei over short distances. So in general, if you have an aerosol generating procedure, they should be placed in airborne precaution rooms. And these procedures include intubation, CPR, bronchoscopy, autopsy, and surgery where high-speed devices are used. So mechanically, the engineering of the room or the hospital should be mechanically ventilated, and it's really an airborne infection isolation room. So that room should have a negative pressure with an airflow differential of more than 125 cubic feet per meter and per minute, and this is determined by the ACH as well. The flow is unidirectional from clean to dirty. The room is adequately sealed with a minimum of 12 ACH. There should be an exhaust or a HEPA filter if the air in the room is recirculated. So before the patient arrives in the clinic and while you're preparing the waiting area, there should be cleaners with protective gears to decontaminate chairs, tables, doorknobs, or exam tables before the clinic starts, during breaks, and after clinic hours. Because we know that COVID-19 persists on wood or metal surfaces, we should cover these with disposable or washable plastic, especially if they come in contact with the patient. We should cover our medical equipment as well, like stethoscopes and probes, and we should do general cleaning at the end of the clinic hour. So we use hypochlorites or chlorine in this dilution. It's a very effective germicidal. And we also can use ethanol at 70%, which is a powerful broad-spectrum germicide and superior to isopropyl alcohol. This can be used to disinfect small surfaces like your thermometers or your stethoscope. However, since alcohol is flammable, we limit its use in small surfaces only and in well-ventilated spaces. Use as a disinfectant can also cause discoloration or hardening or cracking of rubber, so we shouldn't use it very frequently. What about the use of UV radiation as a germicide? So it has been employed in the disinfection of drinking water, air, titanium implants, and contact lenses. So bacteria and viruses are susceptible, but spores are not. The CDC recommends that UV radiation has several potential applications, but unfortunately, its germicidal effectiveness is influenced by a lot of factors like wavelength, organic matter, temperature, and type of organism, and UV intensity. So the application of UV, according to CDC, in healthcare environment like the operating rooms or isolation rooms, is limited to destruction of airborne organisms or inactivation of microorganisms on surfaces, and that no data supports the use of UV lamps in isolation rooms. Even this practice has caused at least one epidemic of UV-induced skin erythema and keratoconjunctivitis among the healthcare personnel and the patients. So the WHO also share the sentiments of CDC. They have no recommendations as regards the use of ultraviolet germicidal irradiation because there's very limited evidence available to suggest that respiratory pathogen spread from patient to healthcare workers or to other patients can be prevented by the use of UV for disinfection in a healthcare setting. What about, I know there are a lot of questions on air purifiers with help of filters. So they can remove pollen and other particles from the air, more than 3 microns. But coronavirus is too small to be detected. So according to Dr. Sorrell, who is a professor in Georgetown, a microbiology professor, the typical HEPA filter is not going to be able to remove coronavirus from the air because it's very small, around 0.1 microns. But if you're going to use industrial grade HEPA filters, then these would be useful. They're usually fixed into the hospital ventilation system. There's also a portable industrial grade HEPA filter that can be used. And these filters are used to temporarily recirculate air in rooms with no general ventilation, augment systems that cannot provide adequate airflow, and provide increased effectiveness in airflow. So these portable HEPA filters are useful to clean the air, especially when the central hospital system is undergoing repairs. However, these units do not satisfy fresh air requirements. Their effectiveness as a portable HEPA filter is dependent on the layout, configuration of the room, the furniture and people in the room, and the location of the exhausts. But if you're going to use an industrial grade portable HEPA filter, They should be capable of recirculating all or nearly all of the room air through the HEPA filter, and the unit should be designed to achieve the equivalent of more than 12 ACH, which is the minimum for an airborne precaution room. So apart from ventilation, how else can we prepare our clinic? Let's place visual alerts like signs and posters at the entrances to pay particular attention on hand hygiene, respiratory hygiene, and cough etiquette. We should ensure supplies are available like tissues, hand soaps, trash cans, and alcohol-based hand sanitizers, and ensure face masks are available for all the patients. So you should create an area to physically separate the patient of 6 feet apart. If your facility lacks a waiting area and you want to reduce crowding, you can ask them to stay in their vehicles and then just wait for their turn. And then in your office, if you have common materials like magazines or reading materials, remove them or clean them regularly. So this is a form of an innovation to for transmission-based as a transmission-based precaution. Goes two ways. So you can have an acrylic box in your clinic so that transmission of COVID-19 can be prevented. So this is the proposed setup. In Dr. Aguilar mentioned earlier about precautions in the ultrasound clinic. So as you can see, there's a physical barrier between the sonologist and the patient. Ideally, if it's by HICO standards, the barrier should be from ceiling to floor. We cover our machines with plastic cover. There are available console covers, but you have to order them. And if you're not able to procure those covers, you can use a cling wrap and still disinfect your machines using low-level disinfectants. So, but you have to look at the instructions first on your machine so that you won't ruin your machine. So clean everything from your console to the trackballs to the keyboards, etc. And place tap water, and then use a damp cloth, soft cloth with soft and non-abrasive liquid soap. And then you can rinse your transducers or your probes with tap water again. And then for those not requiring critical, internal insertion of the probe, like your transvaginal probes or something, for your transabdominal probes, you can use low-level disinfectants like your hydrogen peroxide or glutaraldehyde, but they are according to the manufacturer's instructions. For those, for the transvaginal probes or probes that will be inserted inside the orifice of your patients, you have to use a high-level form of disinfectant. And on the beds, if you, it can't be seen here, we can place disposable plastics on the bed that you can replace with each patient. And here on the left, there is an innovation also for the sonologists. This is not in the guidelines, but we were inspired by the intubation box of the anesthesiologist. So, but these are not in the guidelines. So apart from preparing clinic, you should train and prepare your staff. Ensure that your clinic staff knows how to use, put on, and take off their PPEs very safely. They should be able to recognize the signs and symptoms of COVID, implement procedures to quickly triage and separate the sick patients. We cannot overemphasize hand hygiene and cough etiquette. If they are sick, they are not allowed to enter a clinic, and they're advised to stay at home or seek consult. So Dr. Aguilar already taught you about donning and doffing. Your staff should receive comprehensive training on PPE, how to put on and how to take them off. And they should demonstrate competency in performing appropriate infection control practices and procedures. So in the clinic, at least a level 3 PPE is recommended by the CDCs, because the clinic is also a form of triage. So you have to have your protective gown, your mask, your face shields, your gloves, and your head and shoe covers. So when we are wearing our PPEs, apart from donning and doffing them correctly, they should remain in place and not be adjusted during patient care. They must be removed so slowly, and there should be a step-by-step process. Later on, I'll show you pictures on a safety officer looking over the healthcare personnel donning and doffing their PPEs. So when the patients arrive, your staff at the entrance will ask them about their symptoms, and all patients should wear a mask, actually, especially the symptomatic patients. You limit the non-patient visitors. So you can institute a no mask, no entry policy. Check the temperature of all people and personnel and visitors entering your clinic. We encourage footwear disinfection and the use of stairs, but if you're going to use the elevator, you should only fill it to 25% of its capacity. So separate the sick from the well patients, even outside. So you can create spaces in your waiting area, and place your sick patients in a private room as quickly as possible. So even in your waiting area, you should be able to segregate or separate your high-risk patients, your elderlies, those with comorbidities, and they should practice social distancing. You can use your air conditioners, but make sure to open a door or a window, and you have an exhaust fan. Do not use electric fans because this will create a turbulent airflow. So also, we should prioritize our high-risk elderly patients. After this, so you assess the patient, and after assessing them, they are either triaged to the ER or provided at-home care instructions. So you do the subsequent visits if they can be done by telehealth. And after the patients leave, you have to disinfect, especially the frequently touched surfaces, using an environmental protection agent, but usually it's hypochlorite or 70 environment in the hospital, in your OR, in your DR complex. So these guidelines are from the Royal College of OBGYN, which also based their guidelines on the Infection Prevention Control Guideline of WHO. So if our standard-based precautions like our hand hygiene and respiratory hygiene are insufficient, we do transmission-based precautions. So to minimize contact, droplet, or airborne transmission of COVID-19. So as a standard precaution, we cannot overemphasize hand hygiene as being essential to reduce the transmission of infection. So all staff, patients, and visitors should decontaminate their hands by washing their hands or with an alcohol-based hand rub when they enter or leave the areas where patient care is being delivered. All must perform these hand washings and hand sanitizing should be performed immediately before every episode of direct patient care, and any activity or contact that potentially results in hands being contaminated, for example, in the step-by-step removal of your PPEs. Before performing hand hygiene, make sure that you expose your forearms, remove all your hand and wrist jewelry. Ensure that your fingernails are clean, short. You're not wearing artificial nail products. Cover all cuts or wounds. And if, for example, you contaminated your forearm, you should wash your forearms first and then wash your hands. So as respiratory hygiene as a standard precaution, we practice the catch it, bin it, kill it method. So we use disposable single-use tissues to cover noses and mouths when we sneeze, wipe, cough, or blow our noses. And these tissues are disposed in the nearest trash can, which is lined and foot operated. We wash our hands after or sanitize it with alcohol, and we encourage our patients to keep their hands away from their face. So all patients must wear a surgical face mask. And as regards implementing engineering controls, we should design in the hospital, design and install engineering controls to reduce exposure by shielding our doctors, nurses, and healthcare personnel and our patients from infected individuals. So examples would be physical barriers or partitions to guide our patients when they pass through the triage areas. There should be curtains between patients or in cohort areas. And you should have proper air handling systems installed and maintained. I've mentioned earlier about filtration and ventilation rates, and having the airflow should be unidirectional, etc. So special environmental controls like negative pressure isolation rooms are not necessary to prevent the transmission of COVID-19 because it's droplet transmission. But for high-risk procedures or aerosol-generating procedures, then a negative pressure room is required. So for our patient placements, whenever possible, we should place all suspected or confirmed cases of COVID-19 in single rooms. However, if our single rooms are short in supply and we cannot do cohorting because we're still waiting for laboratory tests, we should prioritize patients with excessive cough and sputum production for single room or isolation placement. So single rooms should be reserved for patients wherein we're going to perform aerosol generating procedures. And we should also allot single rooms among non-COVID patients requiring isolation because of other infectious diseases. So if a single or isolation room is not available, you can place them in cohort for suspects or confirmed cases of COVID-19. But we have to place privacy curtains between the beds to minimize opportunities for close contacts. So if possible, the curtain should be from ceiling to floor. So in the hospital, there should be a designated wing for COVID-19 patients, and this area should include a reception that is separate from the rest of the facility with a separate entrance or exit from the rest of the building. This area should not be used as a thoroughfare where patients can just come and go or healthcare personnel can just pass by. And they should be separated by closed doors with a sign that says that the entrance or exit is are limited. So we also should consider the following factors when we do cohorting of our patients. Shouldn't mix female male patients, but this is not our concern because we're with female patients compromised, and then according to age group as well, if this is possible. So as far as staff cohorting is concerned, we should assign a dedicated team or staff to care for patients in the isolation areas or in the COVID-19 wings. And this should be implemented only when there's sufficient level of staff available so that it will not have a negative impact on our non-COVID patients. And our staff who have confirmed COVID-19, who have already recovered, should continue to follow the infection control precautions like wearing the PPEs. So we should follow for COVID-19 referral center. In the red zone, that's usually the COVID wards and the COVID suspects and the operating room in the third floor and downstairs in the triage. And you should wear appropriate PPEs depending on the area that you are assigned to as a healthcare worker. So usually for dealing with COVID suspects or COVID-19 patients, we're wearing level 4 PPEs. So the next pictures will just show you wards 1 and 3 are internal medicine wards, and these are now designated COVID-19 wards. So before entering the wards, you can see that there's a safety officer making sure that the healthcare personnel are donning and doffing properly. Because we know that the use of PPE is the most visible tool to prevent the spread of infection, and there is a 46% risk of contamination during removal of the PPEs, and as high as 70% if they are incorrectly placed or removed. And if there is a breach in the wearing of the PPEs, the healthcare personnel should report it to the infectious disease or the HICU. As regards managing visitors, so only essential visitors are allowed, and they are also screened in the hospital. Moving men should be limited to essential essential purposes only. The patient is going to be, she should wear a surgery. From clinical departments, for example, the patient is going to go to the to have her X-ray done into the room, and they should not wait in the communal areas. And if possible, like Dr. Aguilar said, patients should be placed at the end of the clinical lists if they are COVID positive patients. So this is an example of the patient flow when we move hospitals, when we move patients within the hospital. So they should have a pathway to prevent transmission. This is also an innovation to transport patients. So this is a stretcher with a PVC frame, a plastic barrier. For critically ill patients requiring mechanical ventilation, we should just make sure that all respiratory equipment has a high efficiency filter. So as much as possible, they should be get decontaminated in accordance with the manufacturer's instructions. So this is also an innovation by the anesthesiologist because intubation is an aerosol generating procedure. So that's the intubation box, acrylic intubation box. In the operating rooms, ventilation in both laminar flow and those with HEPA filters and those with conventional ventilation should remain fully on during surgical procedures and when operating on patients with COVID-19. And we should wear N95 masks, and it should be fitted properly because air can bypass that filtration if you're not wearing it properly. So in the operating room, rapid dilution of the aerosols, if it's properly ventilated, will protect the operating room staff. Diluted and is not considered to be high risk. So the OR should be informed in advance if a patient is going to be transferred, a COVID-19 patient is going to be transferred, and the patient should be wearing a surgical mask unless the patient is oxygen requiring. So the patient is anesthetized, operated on, and recovered in the theater. And the staff should wear protective PPEs, including the transport personnel. Of course, the instruments and devices should be decontaminated properly, and the theater should be cleaned as per local policy. The COVID-19 cases or suspects should be placed at the end of the list, and for patients with possible confirmed or confirmed COVID-19 infection, any of these potentially infectious aerosol generating procedures should be carried out only when essential. And these are placed in, as much as possible, a negative pressure room with the doors shut, and only the healthcare staff who are needed should be present. Patient flow in the operating room. So currently the Philippine General Hospital, the left central block is the COVID operating room. So we have a handoff area, and before it was a pantry, but now it's a dining area. And then there's an ante-room before going to the operating room, which is lined by plastic. This is where the baby is, when you're performing cesarean section. This is where the handoff occurs, or when there are medications needed, etc. So here is the operating room. The machines are lined with plastic, and then you have the lined trash receptacles. So this is the hallway as the patient exits after being monitored inside the same OR theater to the post-anesthesia care unit. But we don't use this anymore because we monitor the patients in the same OR room. So this is the nurse's station lined with plastic. And then the healthcare personnel are made to doff, and then they immediately shower and clean themselves or disinfect themselves after doffing. And they have a separate exit from the operating room complex when they're already clean. So this is from Baguio General Hospital. It's also an innovation wherein the delivery room tables are enclosed in a PVC framed plastic barrier. So this is also a good innovation for transmission-based precaution. So there is evidence for other to have widespread contamination of rooms and environments. So we have to do effective cleaning and decontamination. So the cleaning should be done by a trained staff in complete PPEs using a chlorine-based disinfectant. This is while the patient is in the room. And more frequent cleaning is done for commonly used hand-touch surfaces like the lobby area, etc. And it is strongly recommended that cleaning of isolation rooms is undertaken separately with the cleaning of other areas. So we dispose of the disposable equipment like the mop heads and reuse the mop handles, but make sure that they're also decontaminated. The communal trolley should not enter the room. Once the patient has been discharged or the patient already left the room, clearance of aerosols is dependent on ventilation and air change within the room. So we've discussed that earlier. So a single air change is estimated to remove 63% of airborne contaminants. So after 5 air changes, less than 1% of the original airborne contamination remains in the room. So if you have an isolation room of 10 to 12 ACH or air changes per hour, it takes a minimum of 30 minutes to reduce the contamination to less than 1%. So for negative pressure rooms, you have to leave the room vacant and the door closed for 20 minutes before cleaning the room. The windows to the outside in neutral pressure rooms can be opened. But if you really need the room because there's another operation and you only have one room, then you have to decontaminate immediately. As regards equipment, as much as possible, they're single use, but there are also reusable or communal non-invasive equipment, and they should be decontaminated as properly. So this is when it's between each patient and after after patient use, after blood or fluid contamination, and at regular intervals. So there's no need to use disposable plates or cutlery among COVID-19 or COVID confirmed or suspects. And patient isolation rooms or cohort areas and clinical rooms must be daily decontaminated at least once. But clinical exam rooms should also be decontaminated after each clinical session. So when the patient is finally discharged, the room is cleaned and you now can remove and launder all curtains on bed screens, etc. We require an increased frequency of decontamination where there may be higher risk for environmental contamination, and this includes toilets or commodes and frequently touched surfaces like the doorknobs or toilet handles. So the environment should be kept clean and clutter-free. All non-essential items like magazines or books should be removed from the reception area. But if they are made available, they should not be shared. So that's my last slide. We cannot overemphasize prevention of spread as a #1 priority. Let's protect our healthcare workers, and of course, let's promote patient safety. Thank you very much for listening. I'd like to thank Dr. Angel Bandola for lending me some of her slides. Please don't forget to wear your PPEs. Let's all stop transmission to flatten the curve and take care.
Okay, thank you very much, Dr.